Good afternoon. We continue our discussion, and as I remember, last time we had a stop here at a discussion of chronic diseases of liver, and more specifically on different organs and systems which are affected in chronic diseases of liver. As we probably see from this drawing, there is probably no organ or system in the body which stays normal during chronic liver disease. This is due to many reasons, both in metabolic functions as well as hemodynamic connections with others. Probably we'll not be able to discuss each of them in details, and we'll cover in more details liver or hepatic encephalopathy. We'll talk about mechanisms of systemic hypotension, emphasize some key features in endocrinopathies, mostly related to the fact that liver is an organ where hormones with steroid structure are usually metabolized, so that disease of the liver would result to corresponding increased activity of these hormones, but sometimes with not so expected consequences. In the system of the blood, we may have anemia, which is commonly macrocytic, which is probably not related only to B12 deficiency issues, because it is quite commonly not megaloblastic but just macrocytic. It is explained in various ways, probably not there is no one final solution why it is like that. Probably it is related with changes in the red blood cell membrane. We already mentioned that we might have leukocyte dysfunction and some immune deficiency correspondingly, and in terms of platelets, again, maybe a little bit unexpected for some of us, there is thrombocytopenia, and mechanisms are again not clearly understood. Some authors consider that this thrombocytopenia develops because of increased endotoxin concentration in liver disorders, which results in activation of TLR4 receptors on platelets. The others much more contribute to IgG, which may result finally in immune thrombocytopenic purpura, but these are less clear issues. Hepatorenal syndrome is much more related to damage to the spleen because of hemodynamic relationship with liver, and it is much more about cirrhosis, not just disease of liver. Hepatopulmonary syndrome is very interesting, and unfortunately it is probably beyond the scope of this lecture to discuss mechanisms of hepatopulmonary syndrome, but one important issue is that quite commonly there is hypoxemia in chronic liver diseases, which is probably not due to impaired ventilation. Moreover, sometimes there is increased ventilation of the lungs, but the answer probably should be found within the problems of ventilation perfusion mismatch and impairments in diffusion process. The other system affected is excretory system, and more specifically kidneys, that is called hepatorenal syndrome, and digestive system, which is more than probably others connected directly to the liver, is manifested by mentioned here. But let us start from hepatic encephalopathy, which is very important problem in patients with liver cirrhosis as well as other hepatic disorders, because it is something that directly interferes with the quality of the life of the patient. It is defined as a spectrum of neuropsychiatric abnormalities, which we cannot explain by something else except of liver disease in this case. And main characteristics include changes in personality, intellectual impairment, and a decreased level of consciousness. Quite commonly, hepatic encephalopathy may be signal that the next problem that will develop as a result would be coma. That's why here in manifestations we see finally stupor and coma. But in other aspects, manifestations of hepatic encephalopathy are different changes in cerebral function, quite commonly confusion. One of the characteristic signs, maybe not constantly present, is asterixis, so-called, or flapping tremor, which is found usually if the patient is extending his upper extremities and there is, with not probably very regular way, we can see such a flapping tremor of hands. What are most common causes of this hepatic encephalopathy? Again, American system decides to simplify everything by using such letters as A, B, and C, with A standing for acute liver failure, B is for bypass, means encephalopathy is associated with portosystemic bypass without intrinsic hepatocellular disease, and type C is, we may say, even both, means it is associated with cirrhosis, means there is damage to the hepatocytes, as well as there is portal hypertension with formation of portosystemic shunts. The following classification is clinical, and it requires better understanding of the dynamics of the patient. In very simplified way, we may show the pathogenesis of bypass hepatic encephalopathy by this scheme. Like, we always consider that lots of toxins are made in the gut, which are detoxified in the liver. This is the function of the liver that all of us know, and every time whatever happens, we remember at least this for liver. And when the liver is affected, or even if it is not affected, but if there is portal hypertension and there is activation of portal systemic bypass, we have entrance of these metabolites, including endotoxin, including cytokines, including ammonia products, into the systemic blood circulation, and it is able to affect brain even if the hepatocytes are not damaged enough yet. In hepatic encephalopathy, classically it was considered that the detoxification function of the liver is affected, and that is the main reason why we have a damage to the central nervous system. It is still probably the same, but many new peculiarities are becoming sometimes more important than it was previously thought. But the probably central role here we should again devote to ammonia. Once it was believed that the main source of ammonia is colonic flora, where various bacteria with urease activity are able to synthesize ammonia, which are then entering blood circulation, and if everything is okay with the liver, then the liver is detoxifying it, creating urea, and it is a way we can decrease ammonia in the blood. Main site of the clearance of the body, as we already mentioned, is urea cycle. But also it was shown that even without bacteria, hyperammonemia may develop, which shows that there is also important site of intestine synthesis of ammonia, and there is evidence that some drugs that block intestinal ammonia production may show beneficial effect in treating hepatic encephalopathy, for example neomycin. Another source that contributes to metabolism of ammonia is muscle. Muscle tissue is able to again synthesize glutamine from ammonia, and it may, at least in some moment of time, decrease amount of ammonia by buffering it, because we produce glutamine. But it was also shown that it cannot provide really long-term compensation, because this glutamine will become ammonia back again in the body, so that in cases with cachexia, which sometimes develops in patients with liver failure, it wouldn't be correct to say that decreased muscle mass is having less ammonia detoxification. Rather than itself, this increased catabolism of muscle with eventual production of glutamine or ammonia would be one of the factors that would contribute to hepatic encephalopathy more. And of course kidney, which from one hand is excreting urea, but here is also important that kidney has function of ammoniogenesis, and probably we remember from our previous term discussions that in the proximal tubules there is a mechanism in which the kidneys are able to break down glutamine, and from ammonia and its excretion or secretion to the tubule, we remove also H plus ions by this way, so that this ammoniogenesis was considered as an important anti-acidotic mechanism. But if this mechanism is impaired, or if we have correspondingly change in acid-base balance in the body, this may contribute to increased ammonia production. But anyway, whatever is the site that we discuss, is that the colonic flora, intestine, muscle, or kidney, liver remains the most important site, as we mentioned, because by help of its two mechanisms, first of all, most importantly, in zone 1, as we remember, there is a urea cycle by help of which we detoxify this ammonia, but also zone 3 contributed by synthesis of glutamine. So what happens then to ammonia? Ammonia travels in blood circulation everywhere, and the most important problem is the problem of our central nervous system damage. Ammonia is able to pass through blood-brain barrier, and here we may have problems related with glutamatergic synapses and with astrocytes. To be able to talk about this in more details, I want us to focus on one of such glutamatergic synapses, and to understand the role of astrocytes in the process, we should keep in mind that astrocytes are regulating functions of synapses by help of uptake of neurotransmitters, and then they recycle it and give back to presynaptic terminal. We have lots of disturbances at these synapses, as we'll see later on. First of all, before trying to show or to discuss some key pathogenetic events, we should nonetheless mention that despite the fact that ammonia is so important, there is no direct correlation or positive and strong correlation between ammonia concentration in blood and severity of encephalopathy. Instead, there is such correlation between glutamine level in cerebrospinal fluid and severity of encephalopathy. That's why this picture is shown to emphasize that increased glutamine in cerebrospinal fluid is like cumulative index of how much ammonia we have, because we should consider that glutamine in terms of hepatic encephalopathy is hidden ammonia. Okay, so what happens in the central nervous system at the level of astrocyte synapse contact? Ammonia has lots of damaging effects here. For instance, it is shown that ammonia results in increased aromatic acid entrance into the cells, sometimes with their damaging effects. But probably most commonly cited in different sources issue is the fact that the glutamate that is uptaken from the synapse when it is transforming into glutamine again, then normally if ammonia concentration is normal, glutamine is given back to presynaptic terminal, to presynaptic neuron, in order to continue the functioning of the synapse. But because of such a try to detoxify ammonia, astrocytes, let's say, prefer to keep this glutamine in order to decrease amount of ammonia that we have in extracellular space or in the tissue in general. This increased glutamine might have directly a damaging effect on astrocytes in terms of increasing osmotic pressure in the astrocyte, and that results further in increased water entrance into the astrocytes, and that is known also as morphologically as Alzheimer type 2 cells, which has nothing to do with, of course, Alzheimer's disease, but this is a typical finding in case of hepatic encephalopathy. Also, it is known that expression of some key genes is, of course, impaired in the astrocytes. Another interesting problem arises that due to those favoring those mechanisms which will try to utilize ammonia. One of them is that glutamate may be transformed into GABA. Of course, it is not about the same synapse, but overall in the tissue we might have such a shift from glutamate to a gamma aminobutyric acid, which, as you probably remember, is opposed to glutamate, is inhibitory amino acid. And one other reason why GABAergic signaling may be increased is the fact that there is some increased concentration of neurosteroids in the brain tissue, which all may modulate function of benzodiazepine receptors and also GABA A receptors, thus increasing GABAergic effect. Other systems also involved include serotoninergic system is changed, and there is increased affinity of serotoninergic receptors. So some other authors specify that there is also increase in NMDA receptor activity. So we may come to some kind of controversy because we, from one hand, have clinically decreased alertness, which may be attributed to much more GABAergic effects in the brain. From the other hand, there is some evidence of excitotoxic damage to the postsynaptic neurons, means there is also increased NMDA activity. So in terms of different neurons, we might have both of these changes. Also, it is shown that ammonia may impair detoxification function of astrocytes themselves. Some data like increased mercaptans and butyrate entrance to the system, as well as not showed on in all experiments, but also some data about increased permeability of blood-brain barrier. If we consider that at the same time we have decreased clearance of toxins by the liver, so we have now much more dirty blood and increased permeability for the brain. This all creates difficult conditions for the central nervous system to work with. And one more aspect of glutamine toxicity. Here we see how this synaptic recycling system is impaired in hyperammonemia. You should compare here the size of astrocyte in the from left and right, and we see here that we have now much more glutamine binding with taking ammonia and synthesis of glutamine, which is less given back. The thickness of arrows shows correspondingly processes. Glutamine so accumulates in the astrocytes, resulting in its osmotic swelling. And by the way, this swelling, especially in cirrhotic patients, may contribute to cerebral edema, and itself may contribute to slowly developing coma in much later terms. But another aspect of the same glutamine is that it is shown that maybe not by itself alone as osmotic substance, but also it may act as so-called Trojan horse. The idea is that the so considered in this part of the lecture hidden form of ammonia is glutamine. So when it enters the astrocyte by help of specific transporter, which is histidine-dependent transporter actually, glutamine is taken into the mitochondrium, where the hidden enemy ammonia is again released in the mitochondrium, and in this aspect glutamine is considered as Trojan horse, from which we have now release of ammonia, and inside the mitochondrium this results in deleterious effects, including that of increased production of reactive oxygen species, with damaging Krebs cycle, with final consequence decreased ATP production, and also permeability transition pore opening, which finally results in damage to this mitochondrium and then probably others, which contributes to astrocyte damage. And since sometimes as a joke, sometimes as a serious fact, if astrocytes are damaged, then it is one step before neurons would also be damaged and affected. Another mechanism for increased susceptibility and as well as hepatic encephalopathy is the formation of so-called pseudo neurotransmitters. It is shown that one important enzyme, namely tyrosine 3 monooxygenase, is inhibited in hepatic encephalopathy, which means that within this chain, phenylalanine, tyrosine, and then deoxyphenylalanine, dopamine, catecholamines, here we have metabolic defects. It means that phenylalanine and tyrosine would accumulate increased air concentration, which means that some other unexpected substances may accumulate now, including beta-phenylethylamine and octopamine. They are considered as pseudo-neurotransmitters since they, by structure, are close to catecholamines or dopamine, but in fact they do not have that corresponding activity, which means that in specific brain regions where these neurotransmitters are involved, we would have false activity, and the result is that we have decreased functioning of these important neurotransmitter systems. This slide is actually very much important because it shows that which factors should we consider as precipitants of hepatic encephalopathy, because of course not all cirrhotic patients develop hepatic encephalopathy, but we should be aware of these possible precipitants in order to be able to decrease the possibility of development of this problem. And this includes, as we see, different groups. One is related to the mentioned above increased GABAergic activity, which directly relates with alertness of the patient, and so that's why drugs like benzodiazepines, narcotics, alcohol, they of course will precipitate. Another group is related with increased ammonia production. This is excess dietary intake of protein. Of course, nowadays nobody is claiming that we should decrease protein intake in order to protect liver, because different studies show that it is at least not protective, vice versa, sometimes may worsen the situation. But excess of dietary intake is of course not appropriate, as well as other problems like gastrointestinal bleeding, infection, electrolyte disturbances such as hypokalemia. Let me, since I partially explained why this could be contributing factor, address this question to you. Please think why hypokalemia should be considered as such. The other group includes dehydration, different causes of dehydration of the body. If we have much more portosystemic shunting, it includes spontaneous shunts as well as radiographic or surgically placed shunts in order to counteract with ascites and portal hypertension. And vascular occlusion. Primary hepatocellular carcinoma development is shown here because hepatocellular carcinoma itself is sometimes consequence of long-lasting chronic liver disease and sometimes cirrhosis. Okay, so these were some of the mechanisms that we covered which lead to hepatic encephalopathy. The others are also shown here, and now the main aspect would be that it is not only hepatic encephalopathy but also hepatic coma that may develop due to the same pathogenetic events. We didn't mention this time such factors like bilirubin, about which we will talk later on as jaundice, but of course we should relate it to hepatic diseases because it is also toxic substance. Bile acids, if they enter blood circulation, if we have cholemia, the mercaptans was also mentioned, and pseudomediators, impairments in energy production, different metabolites from the gut, hypoglycemia, because glucose of course was the main source for the neuron, and since we have hepatocyte damaged, we might have low glucose level because of impaired gluconeogenesis, hypoxia of various origins, including that of respiratory problems that we briefly mentioned, then anemic issue, then already mentioned impairment in Krebs cycle, so that there are lots of reasons for neurons to complain from ATP insufficiency, as well as acid-base balance disorders, which are in liver disease again due to many factors, but probably most important is impaired lactate clearance and again impaired gluconeogenesis. So we can see therefore that in hepatic encephalopathy and coma, ammonia is probably most important, but only one part of a puzzle which is really still insufficiently explained overall. And that's why we consider hepatic coma as the terminal stage of hepatic encephalopathy, but it does not mean that it is the end. We still may have chance to bring the patient back. Here we'll make another short break, and I hope that it will not be as long as the previous one, and we'll continue from liver cirrhosis issue next time.